We're going to talk about the effectiveness of substance use disorder treatment and how to actually measure that and gather the data necessary. And to discuss this, I am so glad to have with me today Dr. Annie Peters. She is the Director of Research and Education at the National Association of Addiction Treatment Providers, which is NAATP, which is the leading national effort to further understand substance use disorders through collaborative quality improvement and research. Dr. Peters is a clinical psychologist who has completed her doctorate at the University of Colorado Boulder. She's been working in the addiction treatment field since 2006 with experience in assessment, psychotherapy, process improvement, compliance, counselor education, and clinical leadership. So Dr. Peters, thank you so much. Really glad to have you with us today.
Yes, thank you for having me.
Excellent. Yeah, and we met at the NAATP conference this year, which was absolutely awesome.
Excellent. Yes,
in San Diego, beautiful location. I met a lot of great people. I loved it.
Wonderful. We loved having you there too.
Yeah.
Yeah.
And I was really glad to hear about the Foundation for Recovery Science and Education project. Is you pronounce it FoRSE?
Usually people say FoRSE, but I've heard people say FoRSE, and that's not, there's nothing wrong with that.
So let's say FoRSE. It's an addiction treatment outcomes program.
Mm-hmm.
So if you can start us off by just introducing FoRSE and what is FoRSE and what's the objective?
For sure. Well, NAATP itself has been around since 1978. So, and it's the goal of NAATP really is support of addiction treatment providers of various sorts. And that's what we've been doing for decades. And, through the past decade, I think the focus on treatment outcomes has become more salient to providers and the world in general. Is treatment effective has been a big question. And so, of course, NAATP wanting to support addiction treatment providers said, well, this is a very important thing because in addiction treatment, our history is not, we're not known for rigorous measurement of treatment outcomes, at least in certain sectors or types of treatment. There's not a lot of research or standardization of how we measure recovery from addiction, because that's such a challenging concept. What is recovery from addiction? What does that look like? So NAATP in a couple years ago, we did a pilot study on trying to see what it would look like if we just took, say, residential treatment centers and looked at their outcomes together. And so we did a collaborative pilot project that between 2016 and 2019, and learned that this is definitely possible. Providers want to collaborate, want to measure how they're doing and how to do better at what they do. So since that point, that gave us the roadmap to follow of how to do really good outcomes measurement and research in the field. So NAATP said this topic is so important that we want to develop a research arm and a foundation, a nonprofit 501c3 foundation to build grant money, build the capacity to do this work and to then help and support addiction treatment providers, particularly ones that maybe don't have the capacity to do this work themselves, to really look closely at their outcomes and be able to compare themselves to other programs that maybe are bigger and have more resources. So we wanted to make research and outcomes work accessible to anyone who treats or provides any kind of service, including recovery support for people with addiction, because we all want to do better at what we do, and we're going to learn a lot more if we do it together. So that's why we developed FoRSE, the Foundation for Recovery Science and Education, and why we've launched this addiction treatment outcomes program.
Yeah, so anyone who's investing it all in treatment would want to know, well, is it actually effective? and that this allows for that. So I think of like a client invests their time and effort and money and like, is this actually going to help me? Is this actually going to work?
Mhm.
And compare this program to that program, or outpatient or residential or IOP or PHP, or like what works and what doesn't. Like they're investing their time and money.
Mhm.
Insurance
Oh,
companies, any payer, like you said, grants,
exactly.
and then clinicians themselves greatly invest themselves into treatment, right? Like all of the years of education and how they specialize. I mean, their whole focus is helping clients. So it's a huge investment. And if you don't feel confident in the services that you're providing, if you're not really clear on the outcomes, that makes it difficult, I imagine, for clinicians themselves.
Right.
So yeah, I think like across the board, this is absolutely fantastic.
Mhm.
So be interested to hear, how is this different from the research that's already been conducted in this area?
Mhm. Well, so a lot of research on addiction treatment outcomes comes from publicly funded treatment. So, SAMHSA funded treatment, treatment that accepts any kind of public funding. And we don't have a lot of outcomes measurement on what typically people call rehab, which is often privately funded by whether it's insurance or an employer's insurance, or self-pay, or grants that a person gets themselves, or and we don't know comparisons because rehabs have been around from the peer model for 80 years. And that's where we don't have a lot of research. We also have a lot of research on medication, particularly, you hear medication assisted treatment. So anti-craving medications, agonist medications, things that help people with long-term, with recovery, entering recovery and staying in recovery. But, like you said, the different, outpatient, residential, telehealth, just psychotherapy, whether it's online or in person, 12-step models versus, wholly medication focused models versus cognitive behavioral models, all of that. We've always been interested in what works for what people since, back in the Project Match days, which was the big study that looked at, what approaches work best, but we don't really know what levels of care, systems of care, types of care, settings work the best, and because we don't have that kind of whole scale comparison. So because it's hard to measure recovery, as I mentioned. It's hard to get everyone to use the same measures since there aren't standardized, well accepted measures across the field. So it's challenging work, but as you said, it's really important. So, but how this is different in particular is we're inclusive. We're trying to bring in any type of service. So whether it's recovery support, or a faith-based model, a fitness-based model, a rigorous manualized CBT treatment model, an outpatient medication and medication management model. We want to, or a quote, inpatient rehab. We want to look at all of it and say, what does an episode of this particular type of service look like during the care and post? And so when you mention about, ultimately it's the patients and the clinicians that are really interested in this, is how do we know that we're helping the person in front of us? How do we know that I'm using good models and good research in what I'm doing? But how do I know that this particular person is getting well? Because we don't have, a blood pressure cuff for addiction. So we have to look at drug use and ask them questions, and look at their stress and their sleep and their symptoms. And so we're taking a kind of broad-based, inclusive approach to try to really get all the stakeholders together and start collaborating on what are the best measures, what are the best techniques to measure progress and change in recovery, in treatment and recovery. So that's really, one of our broad-based goals is get the, different stakeholders together, using similar measures, using similar techniques and tools, and talking to each other about what they're finding. So that's what's kind of different about this, is it's not at all narrow, which makes it really challenging, because the narrower any kind of work is, you can stay within your lines, but this one is kind of trying to gather everyone together. So
Yeah,
exciting.
I think trust is so important. I find it hard to know whether or not to trust research.
Yes.
So having a kind of third party, association that's not tied to one particular treatment modality, one particular facility, one particular user group, one particular funding, like not being tied to those things is really important, really can help build trust.
Mm-hmm.
And then also research is very expensive to do well.
Yeah.
So most organizations, I wouldn't think, could do really robust research.
Mm-hmm.
So being able to pool resources into really high quality, effective, trustworthy research is so important.
Right. Yes.
Yeah. One thing I'm curious about is, so, facilities, they will get involved, they'll provide the data.
Mm-hmm.
What about tracking individuals? Because individuals in treatment will go to different facilities throughout the process of their treatment, and also seeing the long-term impact of treatment. It might be hard to follow them after they leave programs. So does the research kind of gather any of that data in terms of following clients, or not at this point?
So at this point from FoRSE, we're not looking at that yet, because we're looking at only de-identified data. And so it's impossible really to follow, well, it's not impossible, but it's very challenging to follow a person across treatment centers. So we're just looking at episodes of care. There's advantages and disadvantages to that. The major disadvantage is what you're talking about, is we're not able to look at that across treatment episodes, across treatment centers. There is work being done by ASAM, the American Society of Addiction Medicine, in partnership with the APA, the American Psychiatric Association, where they're building a patient registry that will do just that, and is really focused on that kind of research. And we have a good collaborative relationship between FoRSE and this program. And so we have different, we're looking at kind of different things. What FoRSE is really looking at the beginning is focusing on getting everyone to the table, building consensus, collaboration, and looking at different episodes of care, and not necessarily following one individual throughout, though that's incredibly important and ultimately crucial to building an evidence-based medicine in addiction. So all of these different efforts that are happening are really important from different perspectives. So,
yeah. And Dr. Peters, how did you get involved in this work?
You mean addiction in general, or in
FoRSE?
Oh, in FoRSE.
Yeah.
So I was a direct care provider for many years, working primarily, I worked in residential addiction treatment as a psychologist, doing co-occurring disorders care. So people who had co-occurring mental health disorders like depression, anxiety, personality issues, things like that. And then did some counselor education on providing treatment, and some leadership positions and supervision. And I do just love I love people who are struggling with substance use disorders. I think I've just seen such incredible transformations for people, and just love the work. And also I realize there's a lot of challenges to, we need to learn how to do it better, because the addiction epidemic is getting worse. And so this research and quality improvement, and really looking at data it is crucial to the future. And also just the racial equity piece. We really need to collect this data and disaggregate it by race and gender and ethnicity and learn, how do we serve different populations and how do we get more inclusion within our treatments of people from different backgrounds and different identities and help them in ways that are specific to them. And so that's where I got excited about having an impact on a broader scale. I love working individually with patients or in groups with patients. And now I love the idea of impacting the field in a broader way. So.
Yeah. And so why do organizations, why do treatment facilities choose to be a part of this and provide the data?
Sure. So we have 50 right now, and it's a really great array of providers. They're not all NAATP members. That's not a requirement. We don't charge a fee to participate. So really what we're offering is if a provider is willing to send us a small set of fully de-identified data, so a little bit of information about the patient, like demographics, things like that, a little bit of information about the service they're providing, length of stay, level of care, et cetera, type of treatment, and then some of the self-reported, patient-reported outcome measures. Then if they're willing to send us that, we sign a data use agreement, and what we provide the service back to them at no charge, we're going to be doing annual reports. And so we'll do one large summary report, which now would be across 50 plus providers, and then site specific reports. And of course, at the beginning, since it's no cost, they'll be fairly simple, but really we want to be able to provide some information to providers on how they're doing relative to providers nationwide. So of course, not everybody, we're not looking at this at first as research, it's more quality improvement. So we don't have rigorous entry requirements. So it's very simple. We say, within this small subset, send us what you have, of different measures, but we don't have 100 measures to choose from. We have a very small number. So if you use one of these, send us your data, we'll benchmark you essentially against this aggregate of other providers and let you know how are you doing. And that's not something that providers can get easily elsewhere. There are lots and lots of softwares that you can purchase that will aggregate your measures compared to others that are using the same software. But what's unique about ours is we basically just have a database and a way to connect to it. And we're not selling a software or a product. A provider can connect to us using their existing electronic medical record or outcomes measurement system or any technology that they're using and keep data in. They can plug into us and send us the de-identified data, and we will then provide them with the annual report. So it's free, it's simple, it's helpful. And so, and it's a good thing. I think we really have been building excitement around it. Providers are saying, wow, I've been waiting for this to happen. And we trust NAATP because you guys are you stand up for ethics and quality. And so we want to be a part of this, to be part of changing the face of treatment and how to get more people the care they need by demonstrating what's effective. So people want to be part of it too, just for not just the business benefit, but the collaboration benefit.
Yeah. In this ranking of effectiveness of facilities, is that made public?
Well, I wouldn't call it ranking because we're not going to say this facility.
I know. I knew that was going to be. I knew that was going to be kind of a catchword.
Yeah.
Yeah.
So yeah, our reports, our summary report will be public. That here's all the data we have, and here's a summary of all the data, and here's who participated. But we're not going to be more specific than that and say, these treatment centers use this measure and here's their outcomes, or this treatment center is the only one using this measure and here's their outcomes. That all we want confidential. So our intention is not to publicly put one against another. We're doing this as a service to the providers. So the only the site or the facility or the treatment provider will see their own data by itself compared to the aggregate. So, and we won't ever, even if we have, let's say we use a measure that only 5 providers are using, we'll have to be very careful, because if we say this is you compared to 4 other providers, we don't want that information to be misused. So, we're providing confidential site-specific reports, and then the only thing that will be public is the aggregate. So
yeah, I can see how that could remove a barrier resistance to organizations being a part of this, and then really empower them to take a critical look at the services that they're providing, how it is that they can improve them.
But you mentioned that the public piece is so important. And so the question is, well, shouldn't the public know who's better than others? And that's where, again, we rely on other folks taking that approach. So that would be Shatterproof is an organization that does a lot of work with the public and helping the public understand what treatment quality is. And that's really their focus, is how do we get this information public? And so we have a good collaborative relationship with Shatterproof, saying all of these aspects are important. Let's work together and find out, here's what we're learning and what is right to make public. And here's what we're learning and what is right to give to the provider so they can do better. So, all of these aspects are really important, which is why we're trying to work collaboratively with the different organizations doing similar work.
Yeah, and why do you think organizations may be resistant to being a part of this?
I guess the one way to say it is fear. Some treatment centers have been in business for a long, long time and have looked at maybe patient satisfaction surveys. And so they see that their patients seem satisfied with their care. And then they have a really good alumni program, and they have people that come back every year for alumni and say, look at how my life is transformed. And so there might be some fear that, well, if we start measuring across more folks, are we going to find out that maybe we're not? And if we start benchmarking against other providers, are we going to find out we're not as good as we think we are, or we're not as good with a certain population or good with a certain presenting diagnosis, but we haven't seen a lot of that. Now, of course, the ones that aren't connected to us are contacting us, maybe, but everyone I talk to says, we're ready. We want to know, because if we're not doing good work, we want to know that. So, but that may be, certainly if we said we're making all this public, I think there'd be a lot more fear. But that's one piece, I think, is what if we find out we're not doing it right? But so far, the providers I've talked to aren't as concerned about that. Another concern people have is the data safe? Are you keeping it safe? And that's really the reason why we started with de-identified data, because we didn't want providers to think that they're sending patient health information, protected health information out, even if they do trust us. What are you going to do with this? So that's why we started with completely de-identified data. So we're trying to kind of address these fears and concerns ahead of time, so that there aren't a lot of barriers to participation.
Yeah, it's clear to me that FoRSE is a powerful force for improving
I think so.
treatment.
Join
yes,
the force, is what we say.
Without data, how do you really know? And without being able to analyze the data, how do you really know? So it could really empower facilities to take a look at, what are we doing? How can we improve? What treatment models might work better for particular people? and just improve the field as a whole. So everyone has to really chip in because everyone holds really important information, really important data. I mean, if an organization has particular treatment models that others don't have, or regions or demographics of their clients are holding really important data for this research that's being done.
Right.
So it's really could greatly help the whole field as a whole.
Yeah. And
Yeah.
data is empowering to the patient themselves. If one thing comes out of what we're doing is that we get more people measuring and giving feedback to their patients about progress during treatment. And then, because we have had that, we've had people join FoRSE and say, oh, maybe I should be measuring not just after treatment, but during. And, some accreditation requirements require that, but some facilities don't do that. So, don't know how, what to measure and at what time point. And we provide guidance on that because we want to empower the patient too, to be able to say, do you know that your craving was up here when you started? And 4 weeks later or something during your program, it's down here now. Now we've got these other things. This depression is still a little high, and we really want to work on that. But you're making really good progress with your desire to use. And that's incredibly empowering to a patient to see that. And so that's, measurement-based care is we want to use measurement to do better care and to communicate with our patients. So, even if that's the only thing that comes out of this is empowering clinicians and empowering patients, then I think we've done a good thing.
Yeah, no doubt. And I'm thinking about ethics, that really any clinician in any field, it's part of most professions ethics to improve the field that they're in and to advocate for clients, to improve services, to be involved in research. So it's part of our ethics, to be a part of such a thing. So is there any way that clients of facilities, clinicians that work in facilities, governments, government bodies, I should say, other associations or organizations, how can those entities help support the efforts of FoRSE?
Yeah. Well, I would say the two biggest ones are providers by joining and sending your de-identified data and participating in the program. And technology supporters. We have a list of technology partners who have done some amazing work, particularly electronic medical record companies, which we didn't know how that would go. We're saying essentially, can you connect to us for your customers and not charge them anything more and just send us some of the data, and because it's the right thing to do. And some have actually done it, and they have made a system that they pull the data out of the EMR, de-identify it, and push it to us, not charging the patient or the patient or the provider. And so, we really rely on them because, they still have all the data, but, we've gotten some to really buy into what you're doing is important. And so we want to provide this service. So that's really important. And then, we've had incredible donors. Most of our donors to the foundation have been larger addiction treatment centers that want to do this work and want to change the field and improve the field. We've also had some private family foundations that want to support certain areas. They want to, say, I want to support providers in this state or this region to get this kind of technology that is needed to do this work, or, I want to support them through you. So we've been able to do that. Ultimately, we haven't applied for a government grant yet, but, we certainly are moving in that direction as we identify real specific research questions. So we'll need support from entities that are funders and can fund this work. And researchers, we're working really closely with researchers at a number of universities right now, more of in a consultative manner, saying, hey, have you thought of this? Have you thought of this? Why not this? And they've been incredibly helpful. And some we're working on actual research partnerships with to say, we kind of want nodes, like this university or this professor is interested in one particular aspect, like maybe recovery capital or opioids or something, like that. And so we want to start that, have research partnerships with different groups to really look at specific questions together. So we need everybody. We need everyone in the room, everyone listening, everyone at the table to be part of this.
Yeah, well, I love the scope of this. So Dr. Annie Peters,
Yes.
thank you very much.
Thank you so much, Ray.
Yeah, and for those of you watching, look at the details of this video, and there's information on how to connect with FoRSE to be a part of this. Thanks a lot.
Thanks so much.